Johnson, and this is The Mebo Show. Twice a month, I sit down with experts on two areas that I'm most passionate about: the music industry and health and wellness in BIPOC communities. Each episode, we have honest conversations with some of the biggest names in hip-hop about their personal wellness journeys. I'm so happy to have my friends at Johnson & Johnson to share their expertise. This show is personal, it's raw, it's real, and I believe it has the power to transform health and change the world.
Good evening. Welcome to our second Wellness Wednesday for the 2024-2025 biennium. I am Elena Meekins-Kent, past Central Regional Representative and current member of the National Physical and Mental Health Subcommittee. I extend warm greetings on behalf of our chair of the Physical and Mental Health Subcommittee, Dr. Charlotte Freeman. We would like to thank our international president, Sor Elsie Cook Holmes, and Sor Pam Smith, our National Chair for Programming, Planning, and Development Committee. As many of you know, Delta Sigma Theta was scheduled to have the Live Well Summit, which was focused on physical, mental, and financial health as part of our programming for the National Physical and Mental Health Committee in the Bahamas this week on October 9th through 13th. And unfortunately, the summit had to be postponed due to Hurricane Milton. The announcement of the postponement was sent to your emails, and additional details will be sent forthcoming. Sor Freeman extends her love and knows we will have a wonderful discussion this evening. We are excited to welcome our Wellness Wednesday, members of Delta Sigma Theta, Polmark, and members of Kappa Alpha Psi, along with our corporate partner, Johnson & Johnson. We believe tonight will be a transformative discussion on heart health, including our very own PMH member, Dr. Donna Wilson. To facilitate this discussion tonight, we welcome Dr. Jabaris Swain.
Good evening, everyone. I'm Dr. Jabaris Swain, Medical Executive for Health Systems Integration at Johnson & Johnson. And I'm excited to moderate this evening's panel, where we'll have an important conversation on heart health presented to you both by Delta Sigma Theta Sorority Incorporated and Kappa Alpha Psi Fraternity Incorporated. Maintaining heart health is crucial for overall well-being, and we'll have a conversation on some important factors that impact heart health. And by addressing these factors, you can significantly improve and maintain heart health over long term. At Johnson & Johnson, we're committed to advancing health equity by addressing disparities in cardiovascular disease, particularly in underserved communities, through innovative solutions, partnerships, and focused initiatives aimed at improving access to care. We hope to absolve the gap that exists amongst people of color in regards to cardiovascular disease. And so this evening, not only will we hear from expert panelists, but we will also have questions to test your fund of knowledge and understanding of cardiovascular disease. We also invite you to place questions in the chat during the discussion. Our team members will be interacting with you in the chat, sharing them with me. Not all the questions will be answered, but we'll certainly try to get your questions. There will be 4 polling questions throughout the webinar. Please respond to them as you are prompted. Now, without further ado, before we get right into the discussion, I'd like to bring on Brother Senior Grand Vice Polmark, Robert L. Jenkins Jr., Esquire, to bring us greetings from Kappa Alpha Psi Fraternity Incorporated.
Good evening and greetings to you all. It is such a pleasure to be here tonight on behalf of our Grand Polmark, Jimmy McMichael, and the entire membership of Kappa Alpha Psi Fraternity Incorporated. The Are You OK program is designed to raise awareness and to educate minorities on health issues like cardiovascular disease and other risk factors. African Americans have higher rates of heart disease than any other racial or ethnic groups. Issues like heart failure, stroke, high blood pressure, and obesity are specific risks associated with heart disease and are all specific touch points of the 35th administration of Kappa Alpha Psi's Are You OK platform initiative. Being an endurance athlete myself, I'm a firm believer of the importance of physical activity, which can help prevent heart disease. Heart disease can also play a factor in mental health concerns like depression. It's okay not to be okay, but you must first address the main question at hand. Are you okay?
Great. Thank you for those comments, Brother Jenkins. Now, let's dive right in and meet the incredible panel of healthcare leaders and advocates who will help educate us tonight. We're going to ask each panelist to share their area of expertise and what their industry or their work involves in regards to helping to address health disparities in people of color. We have three special guests. They include Dr. Donna L. Wilson, Dr. Ronald Andrews, and Dr. Antoine Keller. We'll start with Dr. Wilson. Please introduce yourself, Dr. Wilson, and tell us a little bit about your background.
Good evening. My name is Dr. Donna Wilson, and I am a policy fellow at Chapin Hall. I'm also a licensed professional counselor in the state of Colorado, and my focus has been on health equity and mitigating disparate outcomes for children and families of color. Thank you so much for having me. Excited for the conversation.
Terrific. Dr. Andrews. Okay. Dr. Keller, welcome.
Thank you, Dr. Swain. I'm Dr. Antoine Keller. I'm a cardiothoracic surgeon in Lafayette, Louisiana. And one of the most important things about my job is that I also get to counsel people on wellness and heart health, and have founded a nonprofit organization called HeartSense, which aims to decrease underdiagnosis and undertreatment of structural heart disease and atrial fibrillation in underserved communities. So I'm honored to be here with this esteemed panel, and I look forward to interacting with my fellow cardiac surgeon, Dr. Swain.
Terrific. All right, so we'll go ahead and get started. But before we begin, I just wanted to kind of dovetail off what Brother Jenkins started out with. You know, cardiovascular disease is pretty significant, and there's some numbers that I want to anchor on before we begin to ask the questions of our panelists. According to the CDC, 48% of Black adults have some form of cardiovascular disease, and nearly 56% of Black adults have high blood pressure compared to 48% of white adults. And then when we break it down to gender disparities, Black men are 30% more likely to die from heart disease compared to non-Hispanic white men. And then Black women are 20% more likely to die from heart disease compared to white women. And so those numbers themselves underscore why it's critically important, not only for this forum, but for other conversations for us to have regarding cardiovascular disease. So we'll dive right in, and I'll give my first question to you, Dr. Wilson. What are the most significant barriers to accessing quality cardiovascular care for communities of color, and how can healthcare systems address these challenges from your perspective?
Sure. When I think about some of the challenges, one of the first things that I will talk about is it's just having a limited access to healthcare services. I think primary care specialists and in underserved communities are rare. Sometimes folks have to travel on the highways and byways in order to get services that they need. I think there's also an issue around racism and discrimination. So there's some systemic factors that contribute to chronic stress, and folks just facing large challenges around adversity. I'd also like to talk about the fact that some folks particularly people of color, communities of color, are facing issues around insurance. They're either underinsured or not insured at all. Which again restricts access to receiving medical care. And then there's some implicit bias that some of us face when we go to visit healthcare providers, and that can result in some unequal treatment. I'm happy to go into solutions. I don't know if my panelist wants to add any other factors. If not, then I can tell you a few solutions.
Certainly. Why don't you share?
Sure. I think one of the solutions that we can do is increase the access. We can make sure that people don't have to travel the highways and the byways. That's one of the fundamental principles of I just lost my train of thought here, but we can increase access to primary care. We can also make sure that cultural competence is a main factor with the folks that we are going to see. We can make sure that we're providing training and that healthcare providers understand the importance of, ensuring that each person has what they need in order to be successful and not doing this one size fit all type of treatment plan for folks. We can also make sure that services are rooted in community so people don't have to travel on the highways and byways in order to get the services that they need. And the word that I was looking for that escaped me was making sure that we are following the tenets of the social determinants of health. I don't know why that went away for me in the beginning, but and lastly, what I will say is, just making sure that there is diversity within the healthcare workforce. Representation matters. When we walk into an office and we can see someone that looks like us, it sort of relieves some of that stress and our ability to really think about how to treat, some of this health challenges that we are facing. So I'll stop there.
Absolutely. Now, Dr. Keller, I know you do some great work in the community, and Dr. Wilson mentioned social determinants of health. Do you have any comments on what you believe to be the most significant factors contributing to cardiovascular health in the context of the work that you're doing there in Louisiana?
I do, Dr. Swain, and Dr. Wilson is absolutely correct. There are cultural and social and political and institutional and structural barriers that keep people from getting the care that they deserve. And one of the most interesting things that we found with our HeartSense program, we take artificial intelligence technology into underserved communities to try to understand where the gaps are, where we can do better with regard to providing access to people. One of the most interesting things that we found is that there is a significant undertreatment problem for cardiovascular disease in these communities, but there is an even more significant underdiagnosis problem. And so we have to dissect why we have an underdiagnosis problem. Is it because people don't go to the doctor? Is it because they don't have a doctor in their zip code? Sometimes those two things are true. And the other thing that we found is that if we can give people an idea about how to take care of themselves and things to do to promote their own wellness and give them educational resources that are culturally competent and that are geared towards their literacy level, or what we understand their literacy level to be, we can increase access to people and give them a chance to be able to be diagnosed and be treated in the fashion that everybody else is. And one of the unbelievable things for us is that of all the screening programs that we have a preponderance of women coming to the screening programs and a paucity of men. 85% of the people that we visit with are women. And so we have to do a better job trying to understand how we can get in front of men and how we can encourage them to be responsible for their own wellness.
Awesome. I love that. Now I think it's probably a good time for us to test the knowledge of the audience. Both you, Dr. Wilson, and Dr. Keller shared some really important gems around cardiovascular disease and some of the challenges and barriers that we face as people of color. And so why don't we start with the first polling question? What do you believe is the most significant factor contributing to cardiovascular health disparities among people of color? And so we'll put up some selection choices, and the audience, if you'll type your responses in the comments section, we'll kind of get an idea of where we're tracking. So the choices are lack of access to healthcare, B, socioeconomic factors, C, implicit biases in healthcare, D, environmental factors, or E, lack of awareness on heart health.
Or F, all of the above.
Or all of the above. And so I think this is probably SAT style, where we'll have to pick the best answer, which is socioeconomic factors. But all of the above would also apply. While the factors listed do all contribute to health disparities, socioeconomic factors such as income, education, and employment create significant barriers to access care and managing heart health. These disparities also amplify other issues like healthcare access, environmental risk, and health education. And so while we have a very important election coming up, and one could ask the question, what can we do to address the challenges in regards to cardiovascular disease? One could argue that the single thing, or a single most important thing that can be addressed, is absolve poverty, or get people where they are able to afford and be able to provide equitable access. And so we're going to move on to our next question, but we now have joining us Dr. Andrews. And so, Dr. Andrews, if you would take a moment to introduce yourself and tell us a little bit about your background and how it relates to your work in cardiovascular disease.
Sure, thanks. Great. And I'm glad to be here. I apologize for the technical difficulties as we were coming on. I'd say first I want to thank our Grand Pole March, Jimmy McMichael, our Chair of Health and Wellness, Brother Hernando Carter, and obviously our Vice Chair, Antonio Martez. I'm Dr. Ronald Andrews. I'm a board certified physician practicing both internal medicine and pediatrics. I have an independent private practice, but probably what my keen interest is in being here tonight, I'm the Chief Health Equity Officer of a technology company, 3T Health. And what we try to do is help mitigate those social determinants of health with technology so that we can improve overall health for our patient population. So I'm glad to be here and interested in this conversation as it's been unfolding.
Terrific. Thank you for joining us, Dr. Andrews. And while we have you up, why don't we move to the next question regarding social determinants of health? Dr. Wilson brought it up in her initial comments. And so she helped educate us around the fact that it includes, issues or disparities in housing, income, and education. But for the work that you do, how do these social determinants of health impact cardiovascular health specifically for people of color and their outcomes?
Sure. When I look at social determinants of health, unfortunately, it's a vicious cycle, is what I call it. And we have to find out how we break that cycle to improve overall health. So if we look at the three that were mentioned as it relates to cardiovascular care, we want to look at education, income, and housing. And I think education is the most important because your level of education from early elementary on through high school or college dictates and determines what your overall income is going to be. And you need that income to be able to have quality housing. What we found out is that with lower education levels, a lower income, you usually end up in more dense housing. More dense housing increases your risk for multiple cardiovascular complications. And surely if I start talking about inner city, you start getting to things where your housing, you don't have close, nearby, affordable health care, number one. Number two, you may be in a food desert. Food desert pretty much described as not having a full service grocery store with affordable fruits, vegetables, meats, and poultry within a mile of your house. If we're talking rural, that's probably 10 miles, but inner city, we're talking about 1 mile. And when we talk about social determinants of health, you can look back at those neighborhoods that were traditionally redlined and had the lack of resource and investment. We're talking now almost 90 years ago, coming out of the Great Depression, nearly 95. And those are the same neighborhoods. If you overlay a red line map versus an under-resourced neighborhood, 100 years later, it's essentially the same. So you don't have affordable healthcare, you don't have grocery stores. Oftentimes railroads and interstates intersect directly through the neighborhood. And all those things increase your risk for hypertension, diabetes, and then ultimately obesity, which we know are three main risk factors for cardiovascular disease. So if you have that mixture, it sets you up that if you can't break that cycle where you get more income to live in a better neighborhood, get a better job, so on and so forth, they all compound upon each other.
That's great, Dr. Andrews. But might I double click on something you mentioned about food deserts? There are a good number of individuals who live in those areas where there's a lack of access to healthy foods. But some people are commenting around the context of they may have access to healthy foods, but there's an issue around cost. And then also the issue around changing the mindset of cooking in the house as opposed to eating out in fast foods. Can you comment on how, aside from there being food deserts, but, having access to healthy food options and how sometimes that might be cost prohibitive, and what are some strategies people might be able to take to help improve their health outcomes if they are able to get whole foods, if you will, as opposed to fast foods?
Yeah, no, definitely. I think those are great comments and observations. I think first and foremost, we have to look at socioeconomic factors. And if we go back, I'm not a historian, I promise I was a biology major. But if you look back when I was young, say, go back 40, 50 years, you went to a fast food restaurant as a treat. once a week or on the weekend, or people had birthday parties at McDonald's. Well, now if you start getting into where you're limited with resources, you're looking for that best value meal. So you may have to decide it only costs me $3.99 or $5 right now versus going to spend $65 at the grocery store. Now, I know if we do the math, we could divide that up and how long does the food last and how many people does it serve and how many meals it provides. But you have to have that $65 as the example up front to get the food. So it puts you in a situation where obviously if you work, you have a family, multiple kids, and you're then time constraints. And I'd say, God forbid, Dr. Swain, if you have 3 jobs, just trying to keep the lights on and pay your rent, then it gets a little harder to go and obtain the $65 for the grocery store, have time to cook, so on and so forth. But I think the main thing is probably planning. Planning is everything. So I think you have to plan out those meals, try to your best of your ability, plan out your budget so that if you look at the groceries and can then divide out or extrapolate how many meals that is, how many servings it is, so that you can stretch your dollar. So I believe that there are multiple socioeconomic challenges. And that's why I say, and I may repeat myself tonight, why social determinants is just like a vicious cycle, because one thing affects the other. And it's just, a downward spiral from there unless you can break it.
Right.
It's generational too, as Dr. Andrews knows. You eat things that you eat, and you like the things that you like because your mama and your daddy did, and your grandmama and granddaddy did, and those kinds of things are passed down from generation to generation. So you have to be intentional about breaking that cycle.
Definitely.
Absolutely. And Dr. Keller, while we have you up, I'm going to ask the next question. And if you can start a response, and then I'll get Dr. Wilson to chime in as well. But we're going to shift away from the patient and what they can do as far as the accountability and making healthy options and, preventive measures that the patient can do. But it's also not always the patient's responsibility. There's also some challenges with the professionals or the healthcare system that provides care. So I'd like to pull some of that out for the audience to hear and begin a discussion around what role does implicit bias in healthcare professionals play in the disparities in cardiovascular treatment and outcomes among racial and ethnic minorities? Dr. Keller.
I think it's such an important question because many people don't realize how important it is to have physicians who have the same lived experiences as you do. And I'll give you an example. There are physicians who go to practice in underserved communities that did not come from underserved upbringings and did not have any exposure to underserved upbringings. So they may be incredibly good doctors and may have gone to Ivy League schools and programs just like you did, Dr. Swain. But they may not understand what it's like to have to work 3 jobs and to have to provide for your family and to not be able to go to the doctor because of the fact that you can't miss a day's worth of work. Otherwise, your children don't eat. And it may be inconceivable to them. So it's really important to have physicians that have similar lived experiences or have exposure to those lived experiences to the people that they're treating, because there are cultural and social indicators and barriers that people have to face every day that unless you are familiar with them, you can't understand why someone would not want to be compliant with taking the medication that costs them $1,000 a month. And it's either spend that $1,000 or feed your kids, and you can't have both. So those kinds of things are really important in population health, especially as it relates to underserved communities.
Terrific. Dr. Wilson, can you offer a perspective?
Sure. I mean, I think everything that was just said is spot on. I also think implicit bias impacts how clinical decisions are made. I think it impacts, how you're either overestimated for risk or underdiagnosed for a condition. I think it impacts how trust and rapport is built. Again, not to repeat myself from earlier, but representation matters. And I do think, we fear that in which we don't understand, or we mislabel, the justification for why someone may not do something because that cultural disconnect is there. Lastly, I'll just say, I think negative stereotypes about certain groups get perpetuated, right? And then it impacts the way that a client may be engaged. Language may be spoken that is above a client's education level, as the last doctor just said. So, I mean, there's so many things. They're all interconnected, and it just implicit bias shows up in ways that we don't even imagine that they show up. Just in our basic interaction, right? I'll give you a personal example. My dad suffered from cardiovascular disease, right? We would all show up in the doctor's office together, not because we didn't think that he could not understand, but to be a source of support. We would have a doctor walk in the office and they'd say, "Ooh, I see you brought the whole family." Well, that's not really welcoming. Yes, the whole family is there, but we're part of the tribe. We're part of the solution. We want to hear what you're instructing him to do so that we can then enforce it when we get home. And so I think sometimes, there's these assumptions that get made by providers. And we know that they're there to help, but sometimes the way that they come across may cause some harm. And I'll just pause there.
Awesome. That's great. And Dr. Andrews, you're a provider. So, what are some ways in which, as physicians, we can do better in regards to overcoming those challenges that, Dr. Wilson and Dr. Keller speak of in regards to implicit bias? And then what are some, things that maybe primary care physicians and cardiologists could do better in order to collaborate and ensure early detection and intervention for cardiovascular disease in underrepresented populations is prioritized? Can you offer a perspective?
Sure. I think some of the things that Dr. Wilson surely mentioned earlier in the program is culturally competent care. And as it addresses this question, it's mostly about increasing the amount of minorities, specifically for this conversation, Black doctors in healthcare. And you could probably say nurses, social workers, and everyone else on the team. But increasing the amount of doctors, Black doctors that are taking care of patients definitely helps. Dr. Swain, I never tell anybody switch a doctor if you feel comfortable and you have a great relationship. But we need more Black doctors. And if, I promise I'm biology, not history. But if you look back historically, since, again, the Great Depression, there has not been an increase and actually a decrease in Black male physicians over the last 50 or 60 years that it's been tracked, and Black physicians in general. So as we've increased in population, our number of doctors haven't. And that can go back to, honestly, 1910, and there was the Flexner report. And what many people don't know is there were 7 Black medical schools back then. And after the Flexner report, it got cut down basically to 2, which would have been Meharry and Howard. And then after that, we added Charles Drew and the others, where I think now we're at 5, and Xavier in New Orleans is about to add another Black medical school. And Morehouse, I didn't mention them. So we need more culturally competent care. And I think it's meeting patients where they're at is what I try to do. And I think the problem really becomes only minorities have had to assimilate with society. So I think majority of physicians have never had to think about what it's like to be Black. They may not have had to think about what it's like to be poor, as Dr. Keller mentioned. And just to lighten up the conversation, I'll tell you the way I look at it and how I explain this to my patients is if you tell me, Dr. Swain, I don't know your family. I know some of Dr. Keller's family. I don't know yours, Swain, because Dr. Keller said you were Ivy League. But with the 6 degrees of separation, if you tell me you had a family reunion, you tell me you went to a barbecue at your cousin's house. If I got an idea, okay, y'all had some ribs, y'all might have fried some fish, you got, potato salad, it doesn't have grapes or anything, there's no raisin salad, there's nothing.
No raisins.
But a holiday, you got sweet potato pie and not pumpkin pie.
Right.
And we know that intuitively about our people. And if I had a Latin patient, if I had a patient of a different racial ethnic background, because I'm a minority, I can kind of see maybe what would be different. But the majority persuasion has never had to do that. And while I'm saying this is not to make y'all completely laugh, but I look at it like when you tell me you had your family reunion, what comes to my mind is Pastor Shirley Caesar, when she said, I got greens, beans, tomatoes, you name it. And
Right.
that's what that cultural competence does, because it allows you to see the whole patient and where they are. And then you can help address that maybe that food had a lot of salt in it. And that's why your hypertension and your congestive heart failure and everything else might be out of whack. Maybe those greens are affecting your Coumadin if you're on a blood thinner. So it's so many things that interact with each other. But if you don't have that kind of knowledge, or better yet, you're not open to that kind of knowledge, then there's no way you can know or address those things. So we need more Black doctors is the answer.
Absolutely. Thank you for that. And I can say for sure, Dr. Andrews, that if raisins are in the potato salad, you're going to be excited on the cookout. But you mentioned something really important around representation, particularly amongst the workforce. And I think one other challenge that we have is that we have a lack of representation amongst clinical trials. And because of that, many of the trial results and outcomes that are being used to dictate care to people of color may not necessarily have used them or involved people of color in regards to coming to the outcomes. And so, Dr. Keller, I know you've done some work in clinical trials and some clinical research. I was wondering if you can help us to understand what's the role of clinical research and clinical trials in addressing cardiovascular health disparities, and how can the participation of people of color in such trials be increased?
Yes, this is one of my favorite topics because people don't really understand or really realize the significance of having a paucity of African Americans and Hispanic people in current clinical trials. And I'll use aortic stenosis as an example or a case study. We have a number of randomized clinical trials in valvular heart disease in this country that include about 4% African American individuals and 4% Hispanic individuals. But these two groups combined represent 25% of the population. So there are two problems with that. One is that you can't really make scientific assumptions from the data regarding these patient populations because you don't have enough of them in the population to be able to come to a reliable conclusion. And the other aspect of that is that if you're going to use these clinical trials as the gold standard and you don't have enough African Americans and Hispanics in the trial, then is the outcome of the trial able to be applied to these racial and ethnic groups appropriately? So it's kind of a double-edged sword. So the next question you ask is, why don't we have enough African Americans in the clinical trials? Well, the prevalence data we have for aortic stenosis indicates that African Americans don't have very much structural heart disease or heart valve disease, but we die of heart failure, hypertension, heart rhythm issues, coronary artery disease, and all these other cardiovascular maladies at much higher rates than everybody else. Why are we just lacking in disease death from structural heart disease? And one of the reasons is the data that we have in the literature did not adequately assess the population. It shows a prediction of prevalence from an academic medical center that had mostly insurance patients that did not have enough African American patients to be able to make an adequate representation of what the prevalence is in that community. So we go into the community and we touch people and we find that this prevalence rate is actually many times higher than what is predicted in the literature. So having enough information in the literature that is able to adequately represent these populations is eminently important. And the way that you get to do that is that you have to make culturally competent permission systems for people to participate in clinical trials and to get rid of the hesitancy that many of these African American patients and Hispanic patients feel because of experimentation like the Tuskegee experiment, which Dr. Wilson and Dr. Andrews could probably expound upon. We have to get rid of this hesitancy. And the way that we do that is to be present in the community and to show them that we have a basic need of understanding of what's going on in underserved communities in order to be able to provide useful information about how to treat them and how this data applies to them.
That's awesome. And I think that's an excellent segue for us to bring up our poll question regarding clinical trials. What is the most common barrier to clinical trial participation for people of color in cardiovascular research? Is it a lack of trust in the medical system? Is it limited access to trial locations? Is it a lack of awareness about clinical trials or concerns about time and financial constraints? You can drop your responses in the comments. And while we're getting some of those responses, can Dr. Wilson or Dr. Andrews give us some comments regarding kind of your experience around clinical trials or any statistics that you may be aware of? I can pull those up, but I'd like to hear your thoughts first.
Yeah, I think first and foremost, it's that lack of trust. So Dr. Keller spoke on it. You know, we can go back to Tuskegee experiment, so on and so forth. And so what you do is, as they answer this question, you get a lot of people who do have a lack of trust in the system. They don't want to participate. They're afraid to participate. It often takes time away from your work or your family. And then the reimbursement or payment or gift cards are not that significant enough to sway opinion. So I think it has to be a little more open to get people more interested, because we do need the data. And I would like to actually say something with Dr. Keller that he could probably speak on this topic. The reverse of what we're talking about was when BiDeal came out, Dr. Keller. So there were clinical studies that is using BiDeal by name, but it came out for, you know, the indication was Black people with heart disease, congestive heart failure. But then here was a trial where you have a drug that's saying this is great for Black people, but unfortunately, Black people were afraid to use it. So I think it's a mixed bag of, you know, what comes first, chicken or the egg. We're afraid to be in the trials. We're in the trials and we get the results and then we don't trust it. Mm-hmm.
Absolutely. Absolutely. And I'll just offer some numbers to get perspective, okay. And then we'll get Dr. Wilson's comments regarding clinical trials. But, you know, although Black people represent about 13% of the US population, they account for only about 5% of participation in clinical trials. And that's overall. And then when we look at underrepresentation in drug trials, according to the FDA, 75% of the clinical trial participants for drugs approved between 2015 and 2020 were white, with only 8% being Black and 11% Hispanic. So that was 75% of those clinical trial participants were white and 8% were Black. And then when we look at the different therapeutic areas like cardiovascular disease or oncologic disease, for oncology trials, and this is where some cancer types disproportionately affect people of color, like prostate cancer in Black men, minority participation is notably low. Black patients represent about 4 to 6% of participation in cancer clinical trials. And then it's even lower for cardiovascular disease trials. So there's much work to be done in this space. And what we do know to be true in some regard is that part of the challenge is there's a lack of trust in the healthcare system. But Dr. Wilson, are you seeing other factors that are creating barriers to people of color being involved in clinical trials?
Yeah, I think you hit it on the head. I mean, I think trust is first and foremost, but I think also just like not understanding how that information is going to be used, right? I think there are lots of folks that may have a desire or interest, but I think Dr. Keller had said earlier, you can't miss a day's work, you know, in order to go in and, you know, do your consents and start the participation journey. So, I mean, I think it's hard. I think it's fear. I think it's a lack of education. I think there's some pieces around, you know, policy. You know, I think there's a difference between equity and equality. There's still this sense of if we give all people the same thing, it should work, and that's really not it. We're not talking about equality here. We're talking about equity. Give each person what they need in order to be successful, and it may look a little different. And so until we're a part of those trials where we can see the individual nuances that may exist for a particular population, I think we stand underrepresented in the trials.
And Dr. Swain, if I might add, there are some things that the healthcare industry must do in order to ensure greater numbers of racial and ethnic minorities and people who live in rural communities and people who have a literacy level that might not be up to reading an 8-page consent form can do to be able to ensure more participation and cultural literacy and educational literacy, reading literacy. All of these things have a big impact on whether someone participates in a clinical trial or not. And they need to be addressed a little bit more thoroughly by the healthcare industry in order to be able to ensure that more people from these communities will participate.
Absolutely. And Dr. Keller, to add to that, I can also just highlight a couple of clear mandates that the FDA initiated. The conversation around diversification of clinical trials started in 1993 with the NIH Revitalization Act. And that was, while it was not specific to the FDA, this act plays a fundamental or foundational role in clinical trial diversity efforts. And it mandates the inclusion of women and minorities in all NIH-funded clinical research trials. And more recently, we've seen mandates from the FDA that will require new and upcoming clinical trials to have a diversity action plan, in which principal investigators have to outline what sorts of actions they're going to be putting in place to diversify their trial as they're creating the trials. And that diversification, again, goes beyond just racial and ethnic representation, but also gender and other areas. But I think the highlight of the FDA and NIH in creating mandates for diversification in those trials is just a first step. But if we go back a little bit, and Dr. Wilson, I think this is probably your wheelhouse in regards to public policy and healthcare reform. How can public policy and healthcare reform more effectively target cardiovascular health inequities among racial and ethnic minorities? And what are some other things or suggestions that you found in your work that can be done to help not only diversify clinical trials, but also provide a more equitable playing field for people of color to access cardiovascular health?
Yeah, thank you for that question. Yeah, so one of the things that I say often and frequently in the policy world is, if a policy isn't deemed equitable, can it really be seen as effective, right? I say that all the time. I think there are several opportunities for us when we think about policy related to healthcare. I think we can increase the access for affordable healthcare. And I'll give you an example. Medicaid expansion to help cover low-income individuals, many of which, are the people that we're talking about right now on this call. I think we can, make sure that they have access to health insurance and making sure that it is affordable. I also think there's opportunity to institute implicit bias training into policy so that healthcare providers are not making some of those decisions based on their own bias or assumptions. I think we can incentivize minority inclusion in clinical trials, like the question that we just talked about. Where is the incentive factor? It's all good for the good of science, but how does it help these folks that have to miss a day or 2 or 3 of work? How do we replace that income and incentivize their participation in that way? You talked about NIH a few minutes ago. We can increase NIH funding for cardiovascular disease research, particularly for African Americans and other populations of people of color. And then I think, the big one, we talked about the workforce, right? Let's expand loan forgiveness for minority doctors. That is one way to attract folks to the field and to make sure that our workforce is diversified. Great
response. And I'm just taking a peek in the comments really quickly. And, we're having some reaction to the numbers or the statistics around participation in clinical trials and the diversification, and kind of your comment, Dr. Wilson, around lack of access, lack of representation. But there's a question, and perhaps one of the providers can give their perspective. Are African Americans being invited to these trials, and are there African American doctors leading clinical trials? We talked about mistrust and we talked about policy, but sometimes, that trust can be overcome if the person who's inviting you to the party looks like you. And so, Dr. Keller, is there an issue with, having African Americans or people of color leading clinical trials? And are those who are, I guess, in capacities to lead trials, are they inviting their patients?
No, as you mentioned, Dr. Swain, all of the societies have an understanding that this is an issue. And most of the societies of specialists in this country actually have an action plan to include more minorities in their clinical trials. One of the things that we have done in cardiovascular medicine recently is to try to expand the number of doctors that can enroll patients in clinical trials by going away from academic centers and involving individuals that practice in communities that are historically underserved in private practice, not necessarily as at an academic institution. And the hope is that we can include more people in the community to be able to participate in clinical trials by virtue of the fact that we have more practitioners that come from those communities that are able to overcome the resource challenges that it involves to be able to conduct a clinical trial. For instance, if you're going to hold a clinical trial at your office and you're a private practice doctor, you have to have a clinical coordinator, you have to have a research coordinator, you have to have a lot of people that need to have resources to be able to accomplish the jobs that you hire them to do. So the way that we can get around this is by having more industry support and more institutional support to expand the number of physicians and the resources that these physicians have in communities in which people who come from these underserved groups live and work.
Awesome. I'd like to ask one more question regarding the trials, and then I want to move to one area that we've not touched on, and that's mental health. But I'll go to you, Dr. Wilson, if you can just really quickly comment on a question that we have in the comments around, will possible rulings from the Supreme Court hinder the enactment of diversification mandates even occurring? And so, as we mentioned before, we have a really important election coming up. And depending upon the outcome, may determine how we fare in regards to policy engagement and interaction in the mandates that help, one, diversify clinical trials, but also help avail access to people of color. So just really quickly, can you give us a final comment regarding the policies around, healthcare or cardiovascular care and some things that we should be looking out for when we're going to the polls?
Oh yeah, that is such a loaded question. I'm trying to answer it with with some neutrality, right? I used to work at a place where we were policy agnostic, and so we didn't lean to the left or the right. But what I will say to you all is to be very mindful when you go to the polls, because how you vote will determine what we have access to, what we're continue to do. What sort of things that can come into our community and cannot. So I will just lean there. Yeah. I will just say, vote with your conscience. Make sure that you are thinking about things that are important to you and your community and to your families, and how voting can influence all of those things. I know I did not give you a direct answer, but that's the answer I'm going to give today.
No, that's fine. That's terrific. And I think, that's a perfect place to segue to, because, with the election coming up, that creates a lot of anxiety and stress amongst individuals. And then just living life can create quite a bit of anxiety and stress. And those in combination can impact one's mental health. And so I'd like to start with you, Dr. Wilson, if you could comment on how mental health might affect or be affected by one's cardiovascular health, And then if you could follow up with your experience in that space, Dr. Keller, as a surgeon, because oftentimes we think about, cardiac surgeons as, they think of us as plumbers, but we are also trained to treat the whole patient. And I'm sure there are some mental challenges that you see in your patients. So Dr. Wilson, if you'll start out, Dr. Keller, if you'll comment, and then we'll end with Dr. Andrews and his comments around mental health and cardiovascular disease. Dr. Wilson?
This is what I love about us all being on this panel together, right? We're all from different walks of life. We all, show up in this space in different ways. And what I will say is we often talk about mental health and physical health very separate. And what I want, folks to leave with knowing is that these things are interconnected. They interplay with one another. And so I think mental health support is essential, not only for someone to be able to manage their emotional stress of the diagnosis, but also just to improve their overall cardiovascular health, right? So communities of color, we face unique challenges already. Structural racism, socioeconomic barriers, there's cultural stigmas, all these things, right, around mental health. Do we talk to someone or don't we? Are we crazy? Are we not? Like all these things, right, that we're asking each other. And all of that stuff can just exacerbate not only your mental, but, your physical health outcomes. So when I think about, folks going in and seeking help, like they've gotten the diagnosis, something is wrong, they have high blood pressure or congestive heart failure or whatever the thing may be, they have choices, right? They can go and they can speak to someone to alleviate some of that stress. Think about, individual therapy or someone, that uses cognitive behavioral therapy, to talk to you about how, anxiety or depression or stress is impacting, your overall heart health or your health in general. Or, just the systemic things that we talked about, discrimination or systemic oppression, like using that space to talk and unload. I know that, that may not be for everybody, that one-on-one therapy. So maybe there's a peer support group that, some of our health practitioners can direct someone to so that they don't feel in isolation, that they are, going through this journey alone, but they can talk to peers that are having a shared like experience and get some support in that way. Therapy may not be the thing they want to do at all. So is there a way to tap them into some mindfulness exercises, right? So that they know that when your heart rate is increasing and you're starting to stress out so much, there's strength and power in being able to slow down and to regulate some of those emotions and some of those feelings that you're having. So there is a connection, y'all. I just want you to know that physical health and mental health are not separate entities, but they are interconnected. And that's why I think, again, the power of this panel being together.
Absolutely. Dr. Keller, can you offer a perspective?
Absolutely. I was recently invited to be a guest panelist by Dr. Andrews' brother, Raul Andrews, who's the president of the American Psychiatric Association Foundation, to sit on a panel regarding John Henryism. And it is a really good example of how the brain and the body are interconnected, because John Henryism occurs in Black men, and it's a syndrome that is well recognized in the psychiatry literature. And Black men have a higher rate of stress and a higher rate of chronic stress than most other people in this country as a result of institutional racism and a number of problems that have been perpetuated since the times of slavery. And this leads to increased cortisol levels and increased renin-angiotensin system stimulation and chronic hypertension and chronic heart disease. And Black men actually have a higher rate of suicide following coronary artery bypass surgery. And it is an example of how chronic stress leads to cardiovascular disease and how these things are so intimately connected. And the way that we have to resolve these issues is, as Dr. Wilson said, is we have to understand that this is a problem. This is not just something that you have to suck up and Mr. Martez is really good at trying to bring to mind these ways that Black men can accommodate the stress to reduce their cardiovascular chances of cardiovascular death. And we actually have pathologic studies that show if you have an increased cortisol level and chronic stress, you will have higher levels of atherosclerosis being appearing in your coronary arteries. So there is a connection, and it is a very important connection that we have to recognize and figure out how to mitigate.
Awesome. Dr. Andrews, can you bring us home and help us to understand how some of your patients engage, or kind of, as Dr. Wilson pointed out, how you try to integrate that both mental and physical aspect and make patients understand that they're interconnected as they're trying to address their cardiovascular risk factors?
Sure. I think we have to, obviously, as physicians, treat the whole patient or the entire patient, and mental and physical definitely go together. You can't really have one without the other, with the aforementioned things mentioned by Dr. Keller and Dr. Wilson. I think one important thing in some of the conversation, probably the last 10 minutes, is I want to say first and foremost, if you look at the medical societies, they've had different degrees of their strength of statement, but the American Association of Family Physicians actually came out and said voting is a social determinant of health. So I think that's something we need to realize with these policies and everything we're talking about, getting people in clinical trials, the John Henryism and mental health. That's number one. I think that people can do some deep dive reading. I know we have a very educated audience. If you look at some of the things that everyone was talking about in these last 10 minutes, this is in the Inflation Reduction Act, from the Biden-Harris administration, about what the pharmaceutical industry, the hospitals, and academic centers have to achieve a certain level of diversity in their clinical trials to receive federal funding. So I think it's very important that we mention that. I'd say lastly, I thought Dr. Kelly, he took some of my answer, but the part he left out, I wasn't talking about catecholamines and cortisol and causing hypertension, diabetes, and obesity leading to heart disease. But what he didn't mention, which I know he knows, is two things. The depression and suicide rates after a cardiac diagnosis are astronomical. In the 6 months after having a severe not hypertension, but a severe cardiac diagnosis is astronomical, number one. And if we go back to social determinants of health, the mortality or death of a person having acute myocardial infarction at 1 month after discharge is an astronomically high level if they live in one of these impoverished neighborhoods. So I think all of these things create additional stress. And we have to look at the whole patient and how we treat those things, and that culturally competent care to be aware and knowledgeable of them.
Outstanding. Now, I'd love to continue this conversation, but we are approaching the hour. I really want to thank each of our outstanding guests for the information they've imparted, and just really the interaction that they've had, having come from different backgrounds and giving us, offering different points of views regarding how we can address kind of some of the challenges and disparities that we see not only in cardiovascular health, but also clinical trials. That said, the other unifying theme that exists is that everyone on this panel is a part of an organization that has a wide and broad reach, and our impact can be, pretty significant. And so that said, it'd be great if we could hear, while we have you on the screen, Dr. Andrews, what are some things that we can hear from Kappa Alpha Psi in regards to health? And then we'll have a representative from Delta Sigma Theta come up and share some of the important programs that her organization is able to provide in order to help us along our journey to health.
Sure. Well, I have some exciting things for the brothers of Kappa Alpha Psi. Our Grand Pole Mark, Jimmy McMichael, who we heard from earlier, started a program, Are You OK?, at our National Founders Day this year in January. Are You OK? Started as a mental health component, was the first component, but is going to now join mental and physical health. And what our Grand Pole Mark wants us to do leading up to our conclave or our national convention that will be held in Phoenix, Arizona, is to start a movement, and I really mean physical movement. So an app is going to come out that all of the brothers of Kappa Alpha Psi can log on to, and we want each member and chapter to log their physical activity. So it's going to start with physical activity and your baseline weight, and as we march all the way to Phoenix for our conclave in the summer, there'll be awards per chapter and per province for those who had the most activity and the most weight loss. So you can almost look at it as, Are You Okay is going to culminate with a Biggest Loser competition that will be awarded at our semi-annual conclave.
Awesome. And then I believe Lana Meekins is going to join us really quickly and share with us about 1 or 2 upcoming Delta Sigma Theta programs that viewers can tap into.
Yes, thank you. So the Physical and Mental Health Subcommittee would like to remind you that October is Breast Cancer and Domestic Violence Awareness Month. So chapters should have live well moments around these issues in chapter meetings and on your social media pages to increase awareness of the physical and mental health issues. If you need any additional support around these topics, please reach out to our charitable partners, NAMI and the American Cancer Society.
Outstanding. Those are wonderful programs to share. And we'll make sure that if there are any websites or links that are available, we can drop those in the comments for the audience. And on the part of Johnson & Johnson, I'd also like to just make sure that everyone is aware of our My Health Can't Wait website. It's www.myhealthcan'twait.com. And My Health Can't Wait is a community wellness initiative that we've established to create both in-person events and online resources addressing several medical conditions that disproportionately affect people of color. And resources include a number that are named kind of differently, like Talk That Talk, which is a prostate cancer resource for Black men. That's My Word, which regards multiple myeloma cancer resources for Black men and women. Save Legs, Change Lives, a resource for peripheral artery disease. Depression Looks Like Me, depression resources created for and by the LGBTQ plus community. Research Includes Me, a resource to increase Black and Brown participation in clinical trials. And again, that website is www.myhealthcan'twait.com. We'll put it in the chat such that everyone can see it. And it's free of charge. All those resources are available. There are also a calendar of events that are being hosted across the country. And so each of the programs and others on the My Health Can't Wait website are culturally appropriate education, and that education regards risk factors, what and how to talk to your doctor, how to process diagnosis emotionally, and the resources that we can provide to the community and the better. So, we've talked about a number of different things, both from policy perspective, from clinical trial representation, to things that we can do as patients and consumers of the healthcare system, to what we can expect from our providers and how to hold them accountable. But none of this would not have been possible without the collaboration of Johnson & Johnson with the gentlemen of Kappa Alpha Psi Fraternity Incorporated and the lovely Devastating Divas of Delta Sigma Theta Sorority Incorporated, as well as our esteemed panelists. So I'd like to offer a round of applause, if we could, to each of the outstanding panelists and guests and this outstanding collaboration. Now, looking ahead, please stay tuned for the next episode in the partner series, where we'll dive deeper into issues at the forefront of patient care within the Black community. Again, I'll turn it over now to Alana Meekins from Delta Sigma Theta Health and Wellness Committee to close us out with remarks and to provide a thank you. I, as your moderator this evening, am so grateful and graciously appreciate the opportunity to have shared with you and to have been able to have the opportunity to engage with the outstanding panelists. And I hope that this will not be a one-off, but a trend that will continue and be sustained as we provide more health education resources to our communities and beyond. Thank you.
Thank you. Thank you, everyone, for attending this amazing webinar. We genuinely appreciate it on behalf of the Physical and Mental Health Subcommittee. Thank you for attending Delta's Wellness Wednesday this month and learning about heart health. We invite you back next month for a special election reflection session. We know that you're experiencing some anxiety, joy, excitement, and exhaustion around this election. So we invite you to send in your questions regarding mental health and election reflections to ppd@deltasigmatheta.org. Please send your questions by October 20th to ppd@deltasigmatheta.org, and your question may be answered during that webinar. Thank you all so much and enjoy your evening.